utility of OCTA in this thing. So OCTA has been developed as a substitute to FFA, and it was always thought that FFA had one of the serious side effects, though it was rare, but it has been developed and it has come up to substitute the FFA. And straight going to my the topic there. So if you think talk about the indications of doing FFA in diabetic retinopathy are very clear. We normally follow the guidelines given by the American Academy or some private some preferred practice patterns. So this is the main indications remain. If you want to treat the CSME, that is the main indication, or we want to evaluate the visual loss, or we want to know whether there are any obscure or suspected retinal neovascularization. That those are the only indications where we are doing fundus fluorescein angiography nowadays. Now I'll show that where the OCTA comes into a role when we talk about doing a laser for CSME. Yes, we are doing a laser in few cases of CSME, like non-center involving, where the vision is worse than 20/30. And this is how a fundus fluorescein angiography at the top look like, and how the SCP and DCP, the deep capillary plexus of the OCTA will look like. So on OCTA, if microaneurysms are seen, it has to be seen in the deep capillary plexus, and they are not clearly visible. And those are the areas which we treat for in cases of macular photocoagulation. So eventually, if we are not able to see the microaneurysms clearly, and especially the leaky microaneurysms, so OCTA is of no use in cases of CSME. So these red marks says the macular laser treatment with OCTA is a distant dream, so it doesn't help us there in our clinical practice there. So what about clinical utility of OCTA to evaluate unexplained visual loss? Yes, without injecting a dye, we can see capillary non-perfusion or the macular perfusion areas in the macula. So thus saying that yes, the patient can have a visual loss because of this. And we all know that the superficial capillary plexus and the deep capillary plexus will have different kind of outcomes, and more damage can be seen in deep capillary plexus in this slide. But we all knew that plain OCT can give this information very well. So we don't need OCTA to tell that there is what is the reason for unexplained visual loss. So it may help in evaluating the visual loss, but yes, it is not a definitely, it cannot replace the simple OCT there. Now, the clinical utility of OCTA to find out the NVE or the CNP areas. We all been doing montages or the ETDRS photographs or the wild field to know these. This is how we see these angiograms showing us the CNP areas and the neovascularization. And this is how OCTA will look like. So OCTA, this is a 12/12 scan. Again, it's all machine. Which machine you have? And another one of my colleague has given me this OCTA where they make a montages of the 12/12 scan. So nearly it is covering the whole ETDRS field. So it is clearly, without injecting, we are able to see CNP areas and the neovascularization in these patients. Yes, OCTA helps to pick up neovascularization and CNP areas, but the catch here is which machine you have. Right now we don't have ultra field kind of OCTA images which we need, but yes, it serves our purpose. Once we have treated these patients, we want to know any other areas left, so we can use OCTA to see NV and CNP areas. Now come to the other vascular occlusions, the vein occlusions. Like, I mean, practically there is no indication for CRVO as such for doing an FFA. At best, our clinical practice where we do in CRVO, if you have a minimal changes in the eye, you want to know whether what is the time of the vein perfusion, you need FFA for that, because that is the only thing which is going to tell you that what time the vein is filling, and this is a kind of a impending CRVO, or it's before only FFA can do that. So OCTA cannot do this. So OCTA is not useful in such a situation in case of especially CRVO. And what about BRVO? BRVO we do nowadays, the treatment is anti-VEGF, anti-VEGF and anti-VEGF. Sometimes we have to do grid lasers if patient refuses to get anti-VEGFs. Yes, those patients are there in our poor country. And then we have to do a scatter for NVE. So is there any clinical utility of OCTA in these patients? Because earlier we used to get FFA in these patients and look for perfusive macular edema and non-perfusive macular edema, and depending on the vision, we used to treat them. This is how the OCTA will look like. See a patient there who already been lasered for a inferior temporal BRVO. So the patient has this kind of the OCTA, the capillary non-perfusion on the OCTA, and this is the OCT patient have. So yes, seeing this OCTA, I am able to see, the non-perfusion area. So I may plan a laser seeing this OCTA. I may not need FFA there. So this is again a relatively a fresh BRVO patient. You see that there is a disturbance in the capillary seen in the macular area, and the FAS is broken, and you have this kind of a macular edema. So the patient refuses anti-VEGF. So I can do grid laser seeing the plane, the OCTA in these patients. So grid treatment based on OCTA is may be done in case of a BRVO. And what about a scatter treatment? Yes, again the catch here is the what kind of machine you have. So if you have a machine which gives you a a good 12 by 12 scan, and a very cooperative patient, so that the artifacts are not there, you can pick these capillary non-perfusion areas and the areas of NVE. So this patient has already been treated with you can see the laser marks above, but 3 months later, we can see the NVE. So we thought that is there any area we can retreat? So this is the area we can retreat based on the OCTA. But again, I said the catch is the technology, and the UVF will be better. What about arterial occlusion? It will not show you detect the delay in the perfusion, but yes, the scans look good. Just to say that there is no perfusion, we don't need FFA there. The OCTA suffice our purpose. So this is my last indication, the vasculitis. The vasculitis is basically a peripheral disease. So in a peripheral disease, you will need a peripheral scans. So OCTA per se, the present day OCTA machines do not help us in that. But if you have a machine like which is again given by the same colleague, that which you can make a montage there. So OCTA is able to pick the capillary non-perfusion, which looks similar to the FFA. So yes, the future of OCTA is there in cases of vasculitis. To summarize, in present day, the role of FFA has come down with the OCT, but it has further come down with the use of OCTA there. And the limitations, you all know, remains the artifacts because of the longer duration of the patient, which I have to fix. And of course, the field of view is always welcome. We will all want OCTA from pole to pole, and that will be the best thing to happen to the I think retina practice. Thank you so much.